So I'll start with the case and I'm going to ask questions because I could see a few names. I don't know who that name, which department, but I'm just going to ask randomly. So this is a 14-year-old boy with dengue who came to our ICU. These are all actual cases, okay? He was quite sick, usual vasopressor, IV fluid, ventilation, improved, extubated, and was ready for discharge. And then he started spiking fever, developed tachypnea, required reintubation, and we found profuse yellowish secretions. And this is his chest x-ray. So what do you think happened? I could see Akash's name. I don't know if he's there. Akash, what happened? Anybody? What happened? Why did he deteriorate? What is this?
Ventilator associated pneumonia.
Fantastic. So what he got was a ventilator associated pneumonia. So is that a hospital acquired infection?
Yes.
Yes. Okay. So here we have another lady, a 40-year-old, treated for scrub typhus with MODS. Again, was a very sick patient, ventilation, pressors, transfusion, hemodialysis. As she was improving, again, high-grade fever, and then we got a blood culture which grew Klebsiella. So what is this? Anybody else?
Central
Yes?
line associated bloodstream infection.
Yeah, so you would say a bloodstream infection. It could be central line associated, catheter related. It could be because of the dialysis catheter. See, she was on hemodialysis. So yeah, that's also a central line. So catheter related bloodstream infection, CLAPSI, CRBSI, there are many names, right? So then again, another lady, a 28-year-old lady, postpartum, required multiple ventilation, tracheostomy, medications, and she was actually vegetative, the family was being trained to take her home. She had no indwellings, just a urinary catheter, and still she developed fever, hematuria, and her urine culture grew E. coli. So what is this called now?
COTI, catheter associated.
Yeah, okay. So catheter-associated urinary tract infection, the short form of which is COTI. Right. So all these are examples of hospital-acquired infection or nosocomial infections. And do they happen often or are they very rare?
Very common.
Very common. So the definition is an infection to an organism which was not carried by the patient at the time of admission to the hospital. So anybody who develops an infection in the hospital after a stay of 48 hours, and mind you, this can happen after discharge from hospital. There is another aspect of hospital-acquired infections or nosocomial infections, that is the other term that is used. Infections acquired by healthcare workers due to exposure while working in the hospital. So these are also called nosocomial infections, but today I will not be talking much about them. The principles of prevention are the same. Like already you have heard about needle stick injury. You have heard from Dr. Romi about the lab safety. So that all similar kind of things are important for preventing infections in healthcare workers. And what we do when we all go to RCH, putting on the full PPE to prevent us from getting infected, right? So is it a major problem? Okay. So even in well-to-do countries, it is a major problem. So 2.5 to 25%, I would say in India, it is more between 25 to 30%. In a WHO collaborative study, 8.7%, they covered some 55 countries, several hospitals, and they got 8.7% of hospitalized patients had nosocomial infections. And a report that came out in the BMJ in 2017 is in India, it is at least 15.5 per 100 patients, more than 2 times what we see in European countries and in the US. Unfortunately, we have very little reliable data and there is very little published data on hospital-acquired infection in India, and we hardly have routine standardized surveillance data. So this is again another table that shows, if you see in developing nations, the bloodstream infections in the US on an average would be 2 per 1,000 patients, whereas in India or in other developing nations, it would be 8. It may be much more actually. Pneumonia, it says 5 in the US, whereas it is 13 per thousand patients in developing nations, and UTIs comparatively 3 to 7. Now, what does it do? It's a foolish question, but if you actually look at it categorically, it obviously increases the duration of hospitalization. You have to give antibiotics, so you kind of wait that much longer. It obviously increases the cost of therapy. So those two are the morbidities, and it increases the mortality. Very obvious statements, but we need to keep that in mind. Why is there an increased susceptibility? The host has multiple problems. He is nutritionally compromised. Many of them have compromised immunity, not only because of their diseases, but also because of the drugs that we give them. They are immobilized. And then the environment, they are in close contact with infections. So patients are cohorted together. Fomites, they are touched with all kinds of articles which carry organisms. There is invasion of natural barriers. So we put in central lines, we put in urinary catheters, we intubate them. So all their natural barriers are invaded. The skin gets invaded too. And then anybody who comes into the hospital gets colonized. It can happen as early as a few hours and definitely within 24 hours. And there is so much of antibiotic usage, so there is antibiotic pressure and resistant strains. So the sequence of events, a patient gets colonized, then we breach their natural barriers, their host defense is weakened, antibiotics are administered, which selects out the resistant strains, suitable conditions are present, this colonizer will happily lead to an infection. The sources and the sites, we already talked of them: intravascular catheters, urinary catheters, drains, tubes, implants, respiratory tract, surgical site. Actually, surgical site is one of the most common. And then any of these can disseminate it to bloodstream, which is the most dreaded because obviously it can go anywhere in the body. And not only that, it can then cause even more dangerous things like infective endocarditis and all that. So the classification, there's a very, very long classification. If any of you go through the CDC or WHO documents on hospital-acquired nosocomial infections, it's a long list. Like even pneumonias are classified into hospital-acquired pneumonia, ventilator-associated pneumonia. Then even in ventilator-associated, it's first called ventilator-associated event, ventilator-associated infection, and then you have ventilator associated pneumonia. So it's a long list. And never ever forget, even diarrhea can be hospital acquired. And then, of course, fungal infections are coming up in a very big way and are actually a reality today. So, how do they spread? What's the most important source of spread? Anybody? I know it's almost 5 minutes to 5, so you're all tired. Yes.
It is from the healthcare worker usually.
So which part of the healthcare work?
I mean, hand hygiene.
And
Hands. So the most important, unfortunate, isn't it? We like to think that our hands are the healing hands. We cure patients with our hands. Unfortunately, those same hands are the ones that transmit infection. So nothing is more important than hand hygiene. It is the single most effective method of preventing any kind of hospital acquired infection. And all of you who have gone through RCH know how much you people are looking after your hands. When you doff, you keep on doing hand hygiene like 20 to 30 times. And that is what has actually prevented all of us from getting infections while we have gone through RCH duties, apart from the wonderful PPE that we all get. So if you just look at this normal bacterial skin flora, look at the bacterial count and come to hands of medical personnel, which is much higher colony forming units than, even axilla, which we consider one of the more infected parts or dirty parts of the body, right? So there is a huge burden of bacteria on the hands of medical personnel, and we need to always be aware of it. And the only way of remembering it is that just become obsessed. You should all have a OCN, that whenever you want to touch anything or anybody in the hospital, you need to practice hand hygiene before and after. If this gets ingrained in your minds, you will never be a source of transmission of hospital acquired infection. So we have two kinds of flora in our hands: a resident flora, which is very resistant to removal, and all your hand hygiene does not remove this; transient flora, which is more amenable to removal, and these are the ones that are acquired by healthcare workers during contact with patients or their environment. And these organisms are the one which are associated with nosocomials, while the resident flora is usually coagulase negative staph and diphtheroids. The transient flora are all your Klebsiella, Acinetobacter, and the like. So even clean activities such as checking pulse, blood pressure, lifting a patient, or even touching the patient can transfer 100 to 1,000 colony forming units of organisms. So it is important. So that is why we have to really be careful. And this is how this was a patient with VRE, that is vancomycin resistant enterococcus, who was admitted here. After he has left, every surface that is around this patient's bed is still containing VRE. And you can imagine that if this is not properly cleaned, then the next patient who comes in here is definitely going to acquire VRE, right? So what are the factors that affect transfer of organisms? Obviously, the duration of patient contact. If your hands are wet, that is the worst thing that can happen, irrespective of what it is wet with. Remember, even when you do hand hygiene, your hands should not be wet. You should rub, rub, rub till your hands are completely dry. Okay. Location of healthcare worker, obviously it is higher in ICUs. Long fingernails, jewelry. Many people wear lots of rings on their fingers, nail polish. Those are not good. The bangles, we should be without anything. Our hands should be absolutely devoid of any jewelry. And all kinds of organisms can be transferred: Staph aureus, gram-negative rods, enterococci, and the notorious Clostridium difficile, which is completely dependent on contact uh, transmission. So hand hygiene saves lives. And what do gloves do? They do reduce the degree of contamination. But remember, there could be small defects in gloves, or hand contamination can occur during glove removal, right? So I will just skip this. Important agents, how they reduce bacteria on the hands. Alcohol-based hand rub do not have a long, uh, like they do not give protection for a long time, whereas chlorhexidine will give protection for a long time. So that is why now chlorhexidine-based hand hygiene products are becoming very popular. And alcohol is actually good enough for hand rub. But if you want to wash your hands, then perhaps chlorhexidine is better because the effect will last longer. Now, why do we prefer hand rub to hand wash? Because the time required for a hand rub is just around 20 seconds. And hand wash, there are more chances of drying of skin. And for most situation, except when hands are soiled, hand rub is adequate. So this is important. Hand wash is must when hands are visibly contaminated with blood or body fluids. Like you touch something and there was wetness there because some body fluid was leaking, and you touched that and your hands became wet. After that, you must wash your hands. Hand rub is not adequate. after using the toilet, and before and after eating, right? You use gloves if you anticipate that you're going to touch blood or body fluids, and do not use the same pair of gloves for different patients, and use hand rub after removing gloves also. Now, this is WHO's big campaign which says my 5 moments of hand hygiene, and I will read them out one by one. Before touching a patient, before clean or aseptic procedure, after body fluid exposure risk. So you were, trying to look at the urine and you accidentally, you may not have actually got a body fluid on your hands, but you know that body fluid may be dried on the surface and it could have it. After touching a patient, and after touching patient surroundings. So if you were even to go touch the patient, do something, and then go to the patient's monitor and try to do something on the monitor or the ventilator, ideally in between these two activities, between touching the patient and the patient monitor or the patient equipment, you are supposed to do hand hygiene. So if each of us remembers my 5 moments of hand hygiene, I think that would be a great achievement. The steps of hand rub, I'm not going to say all of you are doing it in RCH. So 20 to 30 seconds, rub hands for hand hygiene, wash hands when visibly soiled, and all the steps. And your hands are safe only once they are dry. I would repeatedly say this, only once they are dry. I find people pouring a liter of hand rub on their hands and rubbing it and not making it dry. So that is actually inadequate. Let us look at some of the site specific bundle approach. So CDC, WHO, any of these organizations have come up with VAP bundle, BSI bundle, UTI bundle. So each of these are basically the evidence-based strategies to prevent the site-specific infection. Most important, bloodstream. So when a CVC is placed, a catheter is placed, the person should be wearing a gown, hat, mask, and gloves, of course. And apart from that, the patient should be fully draped, not just a small drape with a window cut. It should be a drape which covers the entire patient. Prefer the non-femoral route, so the neck veins are preferred. Skin preparation with chlorhexidine is preferred. And once the catheter is already in place, there is no need for daily dressings. But routine inspection of the site of insertion is important to see if it is soiled, if there is blood, or if there is moisture. And if there is blood or moisture, that dressing needs to be changed. Remove if unhealthy. If the skin looks red, if there is a secretion coming out, then it needs to be removed. Aseptic precautions while accessing catheter for IV infusions or sampling. I will not, I am not showing you the picture, but alcohol swabs are available easily in our hospital, and all of you should ask your nurses to indent it so that when the IV site is accessed, they should first swab it with the alcohol swab, and all unnecessary catheters should be removed. Okay. And of course, hand hygiene, hand hygiene, hand hygiene. How infections get in. Even the bottle can have cracks. The junction bacteria can get in. If you're using a medication port or injecting directly into the bottle, that can be a source. Then where the insertion site is, this is a peripheral catheter. You can imagine that this can be multiplied hundreds of times if this is a central venous catheter, and if this bottle is a bottle containing high concentration dextrose like TPN or something. So this is how it should be fixed. See, there's a transparent dressing. If you cannot get a transparent dressing, at least cover it with a gauze so that you can see it, and inspect it every day. And not only that, there should be sutures to keep it in place, because movement is also bad. Anything which is outside, if it moves in, it can carry infection inside. Then we have ventilator associated pneumonia. We elevate the head end of the bed to prevent aspiration. The most important method how a patient develops pneumonia is by micro aspiration. So elevation of the head is important. Maintain good oral hygiene, otherwise it is the organisms from the oral cavity which go down. Tracheal tube with subglottic suction, again to remove those very oral secretions. Stress ulcer prophylaxis. Why? Because it is the chemical pneumonitis which then goes on to a bacterial pneumonitis. Daily sedation interruption and assessment of extubation readiness. So don't keep the tube longer for the duration it is required. Other interventions: use non-invasive ventilation wherever feasible, avoid over-distension of the stomach, good humidification, no mobile condensates in the tubings, avoid unplanned extubations. Now, urinary catheter, use it only when essential, aseptic technique of insertion, proper fixation, and dependent drainage. So I have pictures. See, the person is handling it with a sterile forceps and not using the hand, and proper fixation, pulling and checking, but don't over distend it. Fix it well. There should not be movement. If it is moving in and out, again, the same thing, it will traumatize and cause. And this is a closed system, and this is actually preferred because this has got a very nice all kinds of systems are there that it is no touch, and even the drainage is done without opening the system to the air. And the proper placement, that the bag should always be dependent. You will often find when patient is transported or the bed is being made, the bag is lifted up and put on the bed. That should never be allowed, because reflux of urine occurs from the bag to the patient's urinary system, and that causes infection. Now, isolation precautions, like for example, if you have a patient with C. diff, this patient should be isolated. For contact precautions should be taken. If the patient has respiratory infection, influenza, parainfluenza, adenovirus, droplet precautions should be taken, which we are taking like for corona, and airborne precautions for those with smaller particles, TB, measles, varicella. But actually all this requires a lot of, especially these two require a lot of building modifications, which we do not have in our hospital. Other important measures, I cannot not mention these. You have heard of some of them. Antimicrobial stewardship. Everybody should know why they're prescribing antibiotics, what they're prescribing, how long it should be given, what are the cultures that should be followed up and sent and followed up, and it should be stopped at some time. Appropriate disinfection and sterilization, including cleaning of surfaces in the hospital. Every surface, the beds, as you saw in that picture, needs to be cleaned. Appropriate waste management. Nobody gives importance to this. Those bags that the administration is trying to implement is almost never followed. The sharps are not disposed properly. The glass is not disposed properly. Good lab services to ensure prompt diagnosis of infections and good quality drugs. Now, there are some organizations or whatever, some resources available for infection prevention and control in India. It is very, very, very inadequate. But yet there is actually even Swachh Bharat Abhiyan. If we keep our environment clean, that will in turn decrease the burden of infections. So National Accreditation Board of Hospitals, National Health Missions, National Health System Resource Center, Swachh Bharat Abhiyan, and the Kaya Kalp, which is a clean hospital initiative. We never seem to have heard of it, but it is there on paper. So all these are important. Thank you.